I have no disclosures. So as you've heard earlier, obstruction and reflux and obstruction really result in severe morbidity with the post-thrombotic syndrome. The types of outflow obstruction that we consider are post-thrombotic non-occlusive obstructions, post-thrombotic occlusive, or the non-thrombotic iliac vein lesion, just the typical May-Thurner. So I'm going to give a brief overview of how I do a venous stenting for chronic venous occlusions. The percutaneous endovascular stenting has become the method of choice for treating these chronic occlusions. Technically, it's simple, it's minimally invasive, it can be an outpatient procedure, morbidity is fairly low, and it does not preclude later open surgery if necessary. In terms of procedural supplies, for the access, you'll need ultrasound and a micropuncture kit. For the recanalization, typically an 035 glide wire, straight angled or stiff. Glide catheters, 4 French, 5 French, straight angled are what I use, or some 014 and 018 wires, crossing catheters. And in terms of the treatment, self-expanding stents, 12 to 18 millimeters, 40 to 90 millimeters. In this case, I'm talking about the wall stents. Now, fortunately, though, we do have some new available stents this year. Balloons, 4 to 8 millimeters of the regular pressure, and then high-pressure balloons for post-stent dilatation, usually 12 to 18 millimeters in size. I can't emphasize enough, pre-procedure ultrasound is very helpful to identify your access site. It gives you an idea of the extent of the intraluminal synechiae, measures your vein diameters, determine your landing zone, and evaluate the inflow. So here's just an example of a case, looking here at the common femoral, the flow. Here you can see the synechiae in this area here, and also you can measure your vein diameter. In terms of planning, you want to decide whether you're going to do sedation or general anesthesia. You'll decide ahead of time based on your patient's anxiety level. Positioning, supine, you could do the femoral jugular approach if you want to floss. Prone for popliteal. Plus or minus Foley nowadays, because we're worried about UTIs, we pretty much will do the condom catheters. Again, your options for access are either femoral vein mid-thigh, contralateral common femoral veins if you want to go up and over, internal jugular vein if you're planning to floss to come across, and the popliteal vein. Again, ultrasound, you need to be comfortable with that. Ultrasound guidance to get your access initially. Ensure you identify the tip of the needle and avoid puncturing the superficial femoral artery, which is directly anterior to the vein. And here's just a picture of your ultrasound-guided access. Again, and then you follow the wire up with your fluoro. So in terms of crossing the obstruction for the non-thrombotic lesions or the post-thrombotic that are not 100% occluded, you'll easily cross with a glide wire or glide catheter, which is typically my preference. For the post-thrombotic occlusions that are 100% occluded, they'll be challenging. Procedure time will be prolonged. You'll probably use multiple access sites, crossing catheters, crossing wires, and so forth. Always get oblique views to ensure you're in the area you want to be, especially if you're crossing a chronic occlusion. And after you cross, pre-dilate. The pre-dilatation should not be a large balloon, really 6 to 8 millimeter, just enough to get your stent through. 30-second inflation time, because again, you want to make sure that you oppose that chronic thrombus against the wall. In terms of stent sizing, you can use a combination of preoperative imaging, CT venogram, MR, if present, or you can compare the contralateral iliac vein if it's normal to give you an idea. Intraop Ivis, I don't do a case without Ivis. Measure your diameters and length, proximal and distal landing zone. And it also helps you evaluate the extent of disease, which is really critical for patency of the stent in the long term. If you don't have Ivis, well, you can kind of gauge based on the vein that's being treated. So typically for the IVC, you're looking at a 20 to 24 millimeter stent, common iliac vein 16 to 18 millimeter, external 14 to 16, common femoral 10 to 12. Some deployment tips, and this is specifically for the wall stent. You want to start beyond the lesion, cover below the lesion to treat all of the disease. For the non-thrombotic lesions, you want to start deployment 2 to 3 centimeters into the IVC, not more, because you do want to avoid jailing the contralateral iliac. Use Ivis again to identify the location and extent of disease. And if you are going to use multiple stents, make sure there's a good 3 to 5 centimeters of overlap. You want to determine with Ivis here the location of the femoral vein confluence. That would be your most distal landing zone. And for post-deployment dilatation, you perform it to the size appropriate to the segment. Post-dilate at the end of the stent at the landing zone is crucial to prevent foreshortening. So for example, if your lesion is closer to one end, balloon that side first, because you will foreshorten on the opposite side of the wall stent. High pressure balloons for sure, with prolonged inflation time to ensure that you have adequately insufflated these lesions. And then here's just an example of that post-dilatation. And notice here, we're dilating here, but the stent here is foreshortening on this end. For your completion, multiplane venography, check all angles, and with Ivis as well, to evaluate for any residual compression, incomplete dilatation, or improper stent apposition, all of which you can correct with repeat ballooning. Residual untreated significant disease, about more than 50%, you probably will have to treat with another stent. And don't forget your completion. So in summary, venous stenting can be performed in the setting of chronic venous occlusions. A few technical tips are to cross the obstruction, cover all the disease segments, avoid crossing the inguinal ligament if you can, but not always. Again, you want to extend into the IVC and below the inguinal ligament if you have to cover all of the disease. Make sure you have good inflow and good outflow for good stent patency in the long run, and use Ivis liberally for optimal results. Thank you.